Our first panel today is on the executive order on advancing American kidney health that was signed in 2019, 1 year later. We have with us today four very distinguished and fine public servants. Our first speaker will be Nick Ulecki, Senior Advisor for the Department of Health and Human Services. After Nick, we'll have Dr. Jesse Roach from the Centers for Medicare and Medicaid Services. He will be followed by Melissa Dorsey, also from CMS, and Krishna Patel, also from CMS. Each of these individuals has been actively involved in the implementation of the executive order, in addition to their duties that are ongoing for COVID-19. We're pleased to have them with us today. Nick, why don't you go right ahead?
Hello, everybody. My name is Nick Ulecki. I'm an advisor to Secretary Azar at the Department of Health and Human Services. And thank you very much for having me join you today and give you a little bit of an update on what's going on with the Advancing American Kidney Health Initiative here in the administration. I want to just walk through the executive order that was released and signed by the president last July 10th in 2019, and walk where we are today, and then possibly take one question that I believe that we're prepared for. So, as you know, the executive order was signed, and Section 3 of the executive order asks for an awareness, prevention, and education campaign related to kidney health. Shortly after the start of the implementation of the executive order, we began working with the National Kidney Foundation and the American Society of Nephrology to sign an MOU, and that would involve not just them as partners, but the entire kidney health patient physician community to begin this awareness, education, and prevention campaign, understanding that with such a large population of Americans possibly suffering from prediabetes, the potential for this population to go and eventually worsen, and particularly now during COVID, where folks have been relegated to their homes, gyms have been closed, food access, and as you know, we're working on issues related to social determinants of health. And so access to healthy foods may not be available everywhere. This problem might just be exacerbated. But the problem has been that since the COVID-19 public health emergency began, it's been very difficult for us to move forward on a marketing campaign and promotional campaign to educate Americans on the dangers of kidney disease and renal health. And so where we are today is, after a short pause during the pandemic, we have now begun our meetings again and hope to engage communities like yours to be able to say, all right, America, it's possible that a third of you are pre-diabetic. Prediabetes is just the beginning, and it's not something that people should not be worried about. People should be worried when you have diabetes, and prediabetes is just the beginning step of that. And then obviously there are steps that can be taken to stop to slow it. But, unfortunately, if things continue to progress and get worse, then you head into kidney disease, and then further possibly into kidney failure and end-stage renal disease, or require dialysis or a transplant. And so what we really want to do through this campaign is begin and start to get into people's homes, become a household name, much like you see with breast cancer, prostate cancer, and other disease groups, where people are talking about the importance of bettering their health care and preventing themselves from ever getting into the point where they head into a slide towards kidney disease. And so we're beginning to move again on this educational campaign, and we really do look forward to working with you all, both as patients, patient advocates, physicians, to be able to say it's not just our responsibility as a government or responsibility of different organizations, but patient to patient. That's best methodology of going word of mouth, so that people understand the importance of taking this disease serious and being able to make it something that we can all really work towards bending that curve going forward. The next sections of the executive order, 4 and 5, require us to come up with kidney health models. Section 4 would require us to come up with voluntary kidney models, where we would allow for folks to band together, nephrologists or facilities, folks and stakeholders in the space, to either apply for specialized payment reimbursement changes, so that there's a more holistic or global aspect to the care, so that people are able to provide the services for dialysis patients as well as patients suffering from chronic kidney disease up in the continuum of care, to try to either slow their path towards kidney failure or get them down, when they are on dialysis, into the best, most holistic managed care possible. That essentially providing transportation, that involves education on diet, and being able to provide health care conveniently in facility or at the home, where the patient's already being dialyzed for several hours, and being able to deliver that care in that same location. The other model is a mandatory model that would move and shift the paradigm of dialysis to move more into and to really highlight what is the ultimate goal, which is transplant for every patient that goes into renal failure. It's important because transplant is the one and only best option for these patients. But understanding, if they aren't able to receive a transplant or aren't eligible, we want them to be able to have access to the best care possible. And if they want to receive that care at home or outside of a facility, able to do so. The next section of the paper pushes us towards an artificial kidney. Through programs like Kidney X here at the department, we are putting challenges out there for people to apply their great new innovative technologies to come up with any other options so that supply can meet the demand of the patients that need a renal replacement. In that case, we're in a world where supply has not yet met demand, and we should not live in a world where folks that have gone into renal failure, are on wait lists for lengthy periods of time. So that's one of the goals that the administration has set out over the course of the next 10 years, is to really reduce the amount of folks that are on dialysis, but also increase the amount of people who are able to get access to a kidney transplant or an artificial kidney or other renal replacement. So artificial pancreas, wearable, implantable, and then there's all these cool other things that scientists are working on today. We even heard of scientists growing kidneys in other animals as an example, and we want to incentivize that through innovative grants and competitions. And so that is well underway, and the Kidney X team has been churning throughout the COVID-19 pandemic, and so we expect to make some of those awards heading into the next month or so. The next sections address that same exact issue, just from a different angle. Transplant being the ultimate goal, we want to be able to supply the greatest amount of kidney replacements that we can. The first is a change to how procurement organizations are measured. Currently, through self-reported measures, we do not believe that we're capturing the most amount of available death donor kidneys that could go to patients in need. And so with a change to these metrics, a rule was developed and proposed at the end of last year, which has unfortunately slowed down due to the COVID-19 pandemic. But now we're picking back up and hope to have something out in the next few weeks so that we can continue that push towards making more kidneys available through that death donor process. The next and final section of the executive order addresses the other side of it, living donors. These are people that donate life to others, and one of the things that we have to do is remove disincentives from doing so. And to be able to do that, it doesn't matter if you make $50,000 a year, $200,000 a year. Donating life, donating an organ from your body will and can result in a tremendous amount of stress and possibly time off of work and time away from your family. And so what are those issues? And so through the National Living Donor Assistance Center at HRSA here at HHS, where we have worked to expand the eligibility criteria for folks to be able to donate and receive compensation or reimbursement for lost wages or travel expenses. And we're currently working towards expanding that to childcare and other services for which are currently financial disincentives to living donation. Our hope is that the combination of the last two policies, along with advancements in technology to be able to get to an artificial kidney, and the educational process, as well as the models that we're going to have, will lead to a kidney and renal healthcare space where vulnerable patients are receiving the care where they want to receive it, whether it's at home, in a facility, and they're receiving it with the highest level of technology available. And if and when they're able to get a replacement kidney, that as many kidneys are available and technology catches up and says, you know what, for what we can't do with living or death donor kidneys, we're going to replace with technology, whether and how that works, we've yet to see, but we look forward to see innovative solutions that are pitched. That is generally where we're currently standing. One of the aspects that I wanted to bring up to this community today is to ask that as you've been through the COVID-19 process, public health emergency, and received your care or delivered care, what are the experiences on the ground? What are things that we at AAP can look at and do to help you throughout the public health emergency? We have held public-private partnership stakeholder phone calls repeatedly to get an understanding from the ground, whether it's from nephrologists, nurses, dialysis facilities, technology companies, but particularly patients themselves, to get an understanding of what is getting in the way. The last thing that we need, particularly for this population, is that fear of getting the care that you need is not available because it's something that we did not fix. And so I absolutely encourage you, and we all encourage you, to please get us the stories, get us the information so that we can help. And with that, one of the things that I've been asked to address is, AAKP has been such a great partner from the beginning on both the advocacy side, but as you know, kidney care has largely, until last year, been something that hasn't necessarily caught national attention. The incredible work that you all participated in, along with a lot of our partners, to be able to get to the point where we had a major announcement, a president signing an executive order, shining a spotlight on kidney health. It is a grand step towards what will hopefully be a position that we get in here in the near future, where we are delivering and turning the curve on the amount of folks that pass away each year due to kidney issues. And what we can do going forward is just to continue to levy that passion that you have towards the goals that we have, and to be able to do so, it is, like I said earlier, about the education awareness. That is the true centerpiece of it. And you all are the centerpiece of that centerpiece, if that makes any sense. Grassroots, word of mouth, educating the youth today of America, the consequences of poor diets, or the consequences of not taking care of oneself, and especially the consequence of not taking adverse kidney conditions seriously, will lead to further harm. And so whether it's that way, through these patient groups, through every mouthpiece that we have here at HHS, we're going to encourage this and encourage kidney health to be a pillar of what we want to do to improve healthcare in America. I truly, again, appreciate the opportunity to give you a short update here, even amidst these circumstances of a pre-recorded session. But I really would look forward to see many of you in person again sometime soon, where we can discuss the issues and, again, work towards whatever the next announcement is, whatever that may be, to further and take further steps towards better kidney health in America and advancing the American Kidney Health Initiative. Thank you very much again, and hope all of you have a good rest of your day.
Thank you very much, Nick. I know your schedule is intensely busy, and with the Secretary preparing to go to Taiwan, I know that you'll be working 24/7 for the next couple of weeks. Thank you very much again for joining us. Our next speaker is Dr. Jesse Roach, a very strong patient advocate and a fine civil servant that works at the Centers for Medicare and Medicaid Policy. Dr. Roach was a very instrumental figure as well behind the executive order, who brought to the discussion not only his policy insights, but his insights as a nephrologist trained for pediatrics. Dr. Roach, I'd like to ask you one question here to start the discussion, and that is, in your background as a practitioner and also as a policymaker, have you ever seen a piece of policy or an executive order or a piece of legislation that has so firmly put the patient consumer at the middle of policy decisions?
I think that the kidney initiative and the kidney executive order have been really unique in that they focused a lot on the patient. When we did this, when we started this, we got lots of patient input. It's been important throughout the process before the executive order was done that we had the input of organizations like the AAKP, and that we had numerous calls and meetings throughout all levels of HHS with patients. I think also since the inception of it, this has been a focus of all of us at CMS and at HHS, is to take the patient into account. So if you look at it in terms of home dialysis, that was something that we got a lot of patient input and was driven a lot by patient desires and patient concerns. Or transplantation. One of the things that the big focus on transplantation in the executive orders and our subsequent actions have been with the patient in mind. We want to increase the number of patients that can get off dialysis and get the transplant. So in terms of my history as a government worker and my history as a nephrologist, I haven't seen an initiative that has been so wide-ranging in its drive to help patients, and that has taken patient concerns and patient input in as much as it has.
Thanks, Doc. And then a second question for you. In your background at CMS, can you tell us the important role that patient advocacy organizations play for the civil servants who work there in terms of the issues that we bring to the table and how those issues that we identify as patients and patient advocates impact decision-making within CMS? Thank you.
Every decision that we make is informed by patient decisions and by patient choices and patient input. So, for instance, and I can use a couple of examples that aren't just necessarily related to coverage and then get to the coverage issue. So whenever we make a decision as to what we want to do in terms of if we're going to make a new measure to feel how patients are doing, or if we're going to make a new regulation, all that is involved at numerous levels. So we are in constant contact with any type of policy decision with leadership at the AAKP. We form expert panels that include patient input. Some of those come to us directly via AAKP. Sometimes patients solicit themselves to be on these panels, and sometimes we get them from other patient organizations. But they usually make up a large proportion of a lot of our panels when we're making policy decisions, and they have a strong voice, and it's considered significantly. When we also, whenever we're trying to decide what direction we should go, so not for just specific things, but what's needed, what would be something that we would like to cover, something that we think that's important for us to work on, we get patient input. Again, that's through the leadership of the AAKP. You guys have great leadership and great advocates, but we also like to talk to individual patients. And so even if you're not in leadership, that's an opportunity for you to meet with us, and there's opportunities for you to meet with us and to have influence on our decisions. Finally, when it comes in terms of new innovation for coverage, or whether new innovations are covered, we get patient input. So decisions that happen on what to cover occur from a coverage standpoint. So we have to decide whether or not something's going to be covered, and then we have to decide how much and whether it's going to be paid for. Those steps in those processes, there is patient involvement. There are contractors that are brought in to bring together patients, clinicians, administrators, and they all have voice into determining coverage. We also take into account the needs of patients, and we have physicians and clinicians that are evaluating these things, and they're also coming from the patient perspective. But I think that an important part of this is advocacy that we've gotten from patients. Almost all of our initiatives that we've done and decisions that we've made on how to expand things have come from some patient, from hearing either through clinicians or from patients themselves about a patient need. And so I think the advocacy is important. I think we lean on the AAKP and other groups a lot to sort of drive us as to where to go. And everything we're doing is with the patient in mind. And I think we've done this even more so in the past few years. I think we've increased our reliance on getting patient input. I think it's been something that's been a refreshing change at the agency. And so I think that there's an opportunity to have input and influence on decisions from patient advocacy from a patient advocacy perspective in terms of the coverage. I think it is in terms of the quality measurement. I think it's in terms of the regulations that we do and to see how well we're taking care of you, how we're reporting, how your dialysis facilities are doing, how we're reporting how well transplants are being done, measures about how well facilities are getting transplanted in. I think those all came in with patient input, and I think they all couldn't be done without it. So I think that's it. I think your guys are an important part of our policymaking process, and I love working with you guys at the AAKP.
Thank you very much, Dr. Roach. We appreciate you taking time out of your schedule as well in the midst of COVID-19 and everything you're doing to implement the executive order. Thank you. Our next two speakers are also from the Centers for Medicare and Medicaid Assistance. Melissa Dorsey and Krishna Patel work on the quality improvement and innovation side of CMS. Strong patient advocates, they have their perspective on the executive order and what it has meant for their day-to-day operations over the past year. Go ahead, folks.
Thank you for having us join you today on your third annual AAKP Summit virtually. Today, Krishna and I will talk about putting patients first and other top CMS priorities, as well as emerging directions in CMS-supported quality improvement work as it relates to increasing transplantation. The CMS strategy is built on one main goal, and that's putting our patients first. It is the right thing to do. No one has a greater stake in healthcare improvement than patients. The end-stage renal disease treatment choices, also known as ETC model, developed at the direction of the July 10, 2019 Executive Order on the Advancing American Kidney Health Initiative. The Department of Health and Human Services has laid out 3 goals for improving kidney health. Number 1, introducing the number of Americans developing end-stage renal disease by 25% by 2030. Having 80% of new ESRD patients in 2025 either receiving dialysis at home or receiving a transplant. Number 3, doubling the number of kidneys available for transplant by 2030. Under CMMI's Learning and Diffusion Model Test, Kidney Transplants and Discard Rate, Learning Component, CMS together with the Health Resources and Services Administration, also known as HRSA, will implement the key transplant learning component of the end-stage renal disease treatment choice model. The Division of Kidney Health was established in 2019 to continue to drive progress and results through the ETC Learning Collaborative. In our Division of Kidney Health, we have 18 national ESRD network organizations that continue to make progress to drive results as well as manage in our current COVID-19 environment. ESRD networks work with dialysis facilities and patients to increase the number of patients on a transplant wait list, as well as increase the number of patients on home modality. Now, in our COVID-19 environment, the impact has really been that we've had variable transplant rates throughout the year. Home modality is an important option to reduce the spread of COVID-19. And those are some of the things that we believe are certainly areas that our ESRD networks, as well as some of our work, our charge within the Division of Kidney Health is working towards to address. Now I'm going to hand it over to Krishna.
Thank you, Melissa. So this slide, just addressing some of the needs of ESRD patients. Nearly 520,000 patients are currently on dialysis. The number of patients diagnosed with ESRD grows by 15 to 20,000 annually. ESRD patients make up a small portion of the Medicare population, less than 1%, but they're a vulnerable and expensive population, accounting for 7% of Medicare fee-for-service spending. Medicare funds dialysis at close to $35 billion per year. In addition to major cost savings, kidney transplants can provide patients with far greater health outcomes and immeasurable quality of life impacts. So this graph basically shows a comparison of patient survival for transplants versus dialysis. Data points 1, 2, 3, and 4 represent a high-performing transplant program, a mid-level performing transplant program, a less than average performing transplant program, and those remaining on dialysis. What we see here is that receiving a transplant at a transplant program at any level of performance offers better outcomes than remaining on dialysis. After 3 years, transplanted patient survival ranged from 93 to 96%, compared to dialysis at 79%. At the 5-year mark, transplanted patient survival ranged from 87 to 92%, compared to dialysis, which was at 66%. The 3 main goals for CMS on transplantation and organ utilization are: number 1, to increase the number of ESRD patients who get listed for transplant. Number 2, help more ESRD patients get kidney transplants. And as we mentioned earlier, it offers a greater quality of life for patients, improved health outcomes and length of life, cost savings to Medicare of over $100,000 per patient. And finally, number 3, spread the best practices of high-performing donor hospitals, OPOs, and transplant centers. This offers the pursuit for every available donation opportunity, reduce discard rates, and successfully transplant higher KDPI kidneys. Just some of the stakeholders that we've been reaching out to and requesting their support and commitments to the aims of this initiative. As mentioned earlier, this is truly an all hands on deck effort, and we welcome your thoughts on others we should engage in. So some of the people that we've worked with are dialysis facilities, transplant organizations, donor hospitals, commercial payers, and many, many more. And we're definitely looking for any feedback you may have for our team. So now I'm going to turn it over to Melissa to just go over some of the anticipated timeline of our initiative and further close out the presentation.
Thank you, Krishna. We want to be able to talk about our timeframes for action. Now, the groundwork was conducted by engaging high performers and experts in the transplant community and having a technical expert panel convene in February 2020 to produce 2 change packages. Now, these 2 change packages, one was called the Kidney Utilization Change Package, which was really designed to promote collaboration between transplant programs and OPOs. And the second one was another package called the Kidney Donation Change Package. And that was really designed to promote collaboration between the donor hospitals and the OPOs. Now, some of our other timelines are as follows. In the summer 2020 through the fall 2020, we want to get our infrastructure and contracts in place. Early 2021, we want to be able to enroll our teams. And those teams really consist of all of our organ procurement organizations, 80% or more of our nation's kidney transplant centers, and hundreds of our nation's largest donor hospitals. Now, in spring, summer 2021, we want to be able to initiate our collaborative action. And then moving forward through 2025, we want to be able to generate results. Now, we want to take this opportunity to thank all of you, thank all of our patient leaders for your leadership and teaming with patients, families, providers, AAKP, CMS, and each other. We want to thank you for your commitment and the actions to improve the care of the patients we serve. At any point in time you have any additional questions, please feel free to reach out to us, Krishna and I. Thank you.
Folks, we have a couple of questions for you. First one is, you've been intensely focused on COVID-19 at CMS and also within your division. I'm wondering if you could elaborate for folks on how you've been able to do both COVID-19 and executive order implementation, because your work has been absolutely amazing over the past year.
Thank you for that question. Our response is a little bit multifaceted. We have a lot of individuals within our division that work on different areas of contract work, but we also come together with different responses. And for COVID-19, it was a pandemic that kind of stretched across all the different areas of work. So we've been collectively working as a group on response tactics. So I think that's definitely helped. Another thing is we've had great support from our national support contractor, the Kidney Community Emergency Response, KCER. They facilitate emergency response in the kidney community across the nation. So they have been extremely helpful in this effort. We've also had support from the patients and stakeholders during our COVID response tactic efforts, as well as tremendous cooperation from other federal partners such as CDC and ASPR.
Thank you very much for your answer. Our next question has to deal with your personal experiences as civil servants and as policy leaders at CMS. Can you tell me how patient advocates and patients have impacted some of the understanding you have of kidney disease and some of the things that you look for during the course of your work?
Wow, that's a great question. And I'll start off by saying that our work in the Division of Kidney Health is deeply based on our interactions with our patients. Our patients are really our primary concern, and we listen very closely to our patients to really focus on the work and the areas that are of importance really to them. So within CMS and our Division of Kidney Health, we have our quality improvement leaders hear from our patients on a monthly basis in our calls with our ESRD networks. There are a number of patient learning and action networks in which patient subject matter experts, which we call as SMEs, really design and promote educational tools for our patients and by our patients. There are meetings that include our network representatives, as well as patients that really meet with the leadership on a monthly basis and have meetings weekly during COVID to hear about the impact of COVID on the patients so action can be taken. Every ESRD network has a strong patient representative in the organizational structure, as well as providing a patient voice, which is critical to really all of our education campaigns. Patients are invited to every opportunity to really participate, present, and even interact with our leadership team during various conference settings or different interactions where we have an opportunity for them to present. Now, my staff here within the Division of Kidney Health really continue to have those personal connections with our patients and strive really hard to really understand the challenges and the patients in the communities that we face. I would also leave you all just by acknowledging that, throughout our careers, myself and my entire DKH staff who have these important jobs as a civil servant are really extremely passionate and devoted to our ESRD patients, and will continue to do so.
It's now my privilege to introduce a fellow patient advocate, a member of the board of directors of AAKP, and somebody who's been a true champion for other people. In her own life, Lana Schmidt has seen the power of innovation in medicine and what it takes to actually keep going as a patient and to fight. And now she's one of the prime fighters at AAKP for policy innovation and for patient care choice. Lana, over to you.
Hello, I'm Lana Schmidt, and I'm an AAKP Board of Director and Ambassador. I have experienced acute kidney failure with Goodpasture's disease. It is a very rare disease, and I've never met anyone who has had it. I was on dialysis for over 13 and a half years, and then I've had a transplant for 4.5 years. Because of my rare disease, it was difficult for me to receive a kidney transplant. Had it not been for robust innovation, I may not have received a kidney transplant, and therefore may not have been with you here today to share. I've been actively advocating for kidney health changes for over 10 years. The executive order on advancing American kidney health has been a groundbreaking policy strategy for kidney patient health, creating the framework for medical breakthroughs that kidney patients would have not been able to receive before. It has the potential to completely change the way we administer kidney patients' health and implement a proper system that's conducive for addressing the major kidney issues such as education, dialysis choices, removing barriers, greater access to kidney transplantation, and precision medicine. It includes policies that I and many others have been fighting for a long time. Kidney patients have been uselessly suffering and prematurely dying for way too long. because of an inadequate kidney health care system. Kidney patients have been demanding for a long time for better health care. Now, with the new Kidney Health Initiative, many of us believe that this order marks a milestone where our voice has finally been heard. The executive order sent a clear message that the lives of kidney patients, the disparate outcomes, and the high mortality rates we suffer, and the outdated treatments that we have endured were about to change for the better. Kidney disease, dialysis, and kidney transplantation are all major health events that bring about trauma for patients and families. As I look back now, I can see how each dialysis treatment was a traumatic event, not only to my body, but my emotions and my life. Kidney patients have to fight for their life every day. Receiving a kidney transplant is remarkable, but the surgical process is dramatic and probably ranks up there with being one of the most major surgeries a person could have. To pass through the progressions of kidney disease, it takes great fortitude and resilience of mind and body, of which not all people are able to maintain, and where we have lost many of our fellow kidney patients. This bipartisan, patient-centered policy has outlined a positive path forward for the entire kidney community, especially for patients and their right to choose the best treatments to support their life goals. Kidney patients enthusiastically endorse the executive order, and we appreciate the unique policy victory that we received last year. It is a smart, sophisticated policy that benefits patients and taxpayers alike and marks the start of what AAKP has publicly announced as the decade of the kidney, an era that will be marked by more policy advancements and achievements in the fight against kidney disease. Most importantly, the executive order has given kidney patients hope that their health care would improve, that they are empowered to make decisions that will result in a better life. Let's join together and build on the executive order policy victory. Let's look ahead and scrap this inadequate healthcare system for kidney patients. Let's toss it in the dumpster of medical history and let's write the future. Let's look forward, and in a few years, we should be able to look back and say, the number of people getting kidney disease has lowered. People are doing better on dialysis, and they're getting successful transplants sooner. We've been waiting a long time for this opportunity, so let's get to work and improve the health of kidney patients now. Lives are on the line. Thank you so much for the opportunity to share the patient's perspective on the executive order.
I'd like to thank our guests for our first panel today. They offered a federal perspective on where we are 1 year later on the executive order on advancing American kidney health. Thank you very much.